Okay, guys. Now let's talk about rheumatic fever. So rheumatic fever, this is caused by group A beta hemolytic streptococcus. In short, we call this GUPS. Group A beta hemolytic streptococcus. Now this understand this bacteria is having a protein called M protein. And the structure of this M protein is similar to body's protein. So what happened? Body get confused. Body get confused means generally two organs are confused. First is your heart, and second is your kidney. So understand, when heart get confused, then the disease is called as rheumatic fever. And when kidney get confused, then what we call this? We call this PSGN. So understand, mechanism is same, and this phenomena is what we call this molecular mimicry. Molecular mimicry. So this is basically due to M protein. So initially understand, patient will have history of sore throat or pharyngitis. So patient will have sore throat, or sometime I can say patient will have skin infection. So this is something which is, I can say, very common in children which are 5 to 15-year-old. 5 to 15-year-old. So initially what we call this rheumatic fever. As disease progress, then we use the term rheumatic heart disease. Rheumatic heart disease. Now understand this thing, what they ask you in exam, they ask you in rheumatic fever or rheumatic heart disease, most common valve involved, this is your mitral valve. So patient can develop both MS as well as MR. Both can occur, mitral stenosis as well as mitral regurgitation. So how we make a diagnosis? To make a diagnosis, understand what we need. We need either antibody for is positive, that antibody is called as ASLO. ASLO means anti-streptolysin O. Anti-streptolysin O. This antibody should be ASLO. ASLO means anti-streptolysin O. Anti-streptolysin O. This antibody should be positive. And along with this antibody ASLO came in your exam. This is not an exam question. And along with this, what we need a revised Jones criteria. Revised Jones criteria. So in this Jones criteria, what we have some major criteria as well as minor criteria. So let's understand this thing. What is this Jones criteria? So we have J4, joint involvement. Joint involvement means migratory polyarthritis. Patient will complain sometimes having pain in this joint, then this joint, it will move. O means obviously heart. So in heart, it will cause pancarditis. Pancarditis means it could be endocarditis, pericarditis, myocarditis. And 4, nodules. Nodules means patient will have subcutaneous nodules. E, very, very important, erythema marginatum. Now see, this is erythema marginatum, not erythema nodosum. Erythema nodosum is something which we see in sarcoidosis or drug-induced hypertension. So in heart, it will cause pancarditis. Joint involvement means migratory polyarthritis. Patient will complain sometimes having pain in this joint, then this joint, it will move. O means obviously heart. So in heart, it will cause pancarditis. Pancarditis means it could be endocarditis, pericarditis, myocarditis. And 4, nodules. Nodules means patient will have subcutaneous nodules. E, very, very important, erythema marginatum. Now see, this is erythema marginatum, not erythema nodosum. Erythema nodosum is something which we see in sarcoidosis or drug-induced hypersensitivity. S is synonym chorea, and with S we have one more thing. Understand this thing. Patient will not have symptom. Without symptom, but he's having carditis. That's called subclinical carditis. So how we diagnose this? It is diagnosed in echo. Subclinical means no symptom. So subclinical carditis in echo, this is a newly added feature. A newly added, that's why we call this revised Jones. So this is about major. Now coming to minor criteria. So understand, rheumatic fever, very, very important. Fever, name is having fever, but fever is minor. Second important thing, understand this thing, joint pain. Joint pain is minor, but the joint inflammation is major. Then third is increase in ESR. ESR increase, that is your minor criteria. Fourth, I can say increase in CRP, C-reactive protein increase. And fifth is ECG changes. So ECG changes means in ECG you will see increase in PR interval. Increase in PR interval. So these are minor. Now understand, when we see rheumatic fever patient, you will see patient will develop vegetations. So you can see this is vegetations, and these vegetations are seen along line of closure. Vegetation means as disease progress, you will see some fibrin layer is depositing, and these vegetations are seen along line of closure. In short, I'm writing LOC, line of closure. Then in rheumatic fever, you will find dystrophic calcified body. These bodies are called ash of bodies. Ash of bodies. So this is your ash of bodies. Then you can see these type of cells. So suppose if I redraw these cells, they look line of closure. Rheumatic fever patient, you will see patient will develop vegetations. So you can see this is vegetations, and these vegetations are seen along line of closure. Vegetation means as disease progress, you will see some fibrin layer is depositing, and these vegetations are seen along line of closure. In short, I'm writing LOC, line of closure. Then in rheumatic fever, you will find dystrophic calcified body. These bodies are called ash of bodies. Ash of bodies. So this is your ash of bodies. Then you can see these type of cells. So suppose if I redraw these cells, they look like a caterpillar. We call them caterpillar cells. These are nothing. These caterpillar cells are modified macrophage. We also call them caterpillar cells or NHCO cells. NHCO cells. These are modified macrophage. So ash of bodies, understand, these are the bodies which will contain these NHCO cells. This will have T lymphocytes, plasma cells, and fibrinoid necrosis. And just remember, these ash of bodies, they are made up of dystrophic calcification. So they ask you ash of bodies, these are the pathognomonic feature of rheumatic fever. Now they ask you how we treat the patient. So understand this thing. For treatment, what we give benzathine penicillin. If patient they develop allergy to penicillin, in that case, what the alternative is? Alternative will be azithromycin. Azithromycin. So this is something which you have to remember about rheumatic fever. Now let's talk about endocarditis. Endocarditis. So before this thing, what is this Jones criteria? So we have J4. So suppose if I redraw, this will have T lymphocytes, plasma cells, and fibrinoid necrosis. And just remember, these ash of bodies, they are made up of dystrophic calcification. So they ask you ash of bodies, these are the pathognomonic feature of rheumatic fever. Now they ask you how we treat the patient. So understand this thing. For treatment, what we give benzathine penicillin. If patient they develop allergy to penicillin, in that case, what the alternative is? Alternative will be azithromycin. Azithromycin. So this is something which you have to remember about rheumatic fever. Now let's talk about endocarditis. Endocarditis. So before moving to endocarditis, let me tell you about how we see endocarditis per se. So we have different type of endocarditis. First endocarditis is called acute endocarditis. Acute endocarditis, understand, this is something which is affecting those individuals who are taking some IV drug. So it is affecting IV drug abusers. So those who consume some IV drugs like IV heroin. So these IV drugs, they are prone to develop Staphylococcus aureus infection. So this is caused by Staphylococcus aureus infection. Second type of endocarditis is called SABE. SABE is subacute bacterial endocarditis. This is something which is caused by Streptococcus viridans. And this is clinically very, very important, because to make a diagnosis, what we have a criteria called Duke's criteria. Just remember, Duke's criteria is for SABE, Duke's scoring or Duke staging, that is for colon cancer. Now, third type of endocarditis, understand, it is seen in SLE patient. This is called as Libman-Sack endocarditis. Libman-Sack endocarditis. So this is something which we see in SLE patient. Fourth type of endocarditis, understand, this is endocarditis that we see in those patients who have some sort of cancer. It is called as NBTE. NBT is non-bacterial thrombotic endocarditis. We also call this Rheumatic endocarditis. Rheumatic endocarditis. So this is seen in cancer patient. Actually, it is, I can say, a paraneoplastic symptom of certain cancer. Fifth type of endocarditis, I can say. So this type of endocarditis, you will see it is affecting those individuals who have some artificial valve or prosthetic valve. So understand this thing. Prosthetic valve endocarditis means it is affecting those individuals who have some artificial valve, like after valve replacement surgery. Then compare this with those endocarditis, we call this native valve. Native valve means those who have natural valve, like you and me. So native valve. So we can have prosthetic valve endocarditis and we can have native valve endocarditis. Prosthetic valve, native valve. And sixth type of endocarditis, I can say it can occur due to rheumatic fever. So we call this rheumatic endocarditis. Like in rheumatic fever, I told you pancarditis. So pancarditis can also have endocarditis. Pan means whole. It is called rheumatic endocarditis. Rheumatic endocarditis. So these are different types of endocarditis, but an exam point of view, what is important, it is SABE. Now understand, this is about SABE. SABE means subacute bacterial endocarditis. It is caused by Streptococcus viridans. So this endocarditis, understand, this will have vegetation, and these vegetations are fragile vegetation. Fragile vegetation means they will fall. They will fall, so they can form embolus. So in this endocarditis, we will have a lot of feature. And to make a diagnosis, so diagnostic criteria that we have is called as Duke's criteria. Duke's criteria. So understand, when these vegetation will fall, you can see different manifestations. So sometimes you can get a spot in the eyes. These spots are called Roth spots. Roth spots. Then understand this thing. Suppose sometime you will see like patient will have lesions in the skin. These lesions are called Janeway lesion. Janeway lesion. Third thing is you will see a similar lesion like Janeway lesion in the skin, in the palms and soles. We call this Osler nodes. And you can see nail will have this hemorrhage. You can see nail bed will have hemorrhage. This hemorrhage is called as splinter hemorrhage. Splinter hemorrhage. So nail bed image, you can easily figure it out. But how we differentiate Osler node and Janeway lesion, understand this thing. When you have pain, what you will shout? You will shout, oh my God. Oh my God means O for oh my God, O for Osler nodes. So this is something which is painful. It is a painful condition. And when you have a Janeway lesion, you are J for Janeway lesion, J for just relax. You are just chilling or relaxing. So it is something which is painless. So understand this thing. Osler node and Janeway lesion, they look alike, but how we differentiate? Osler nodes are painful, Janeway lesion are painless. So this is about the endocarditis which you have to remember.